Choosing the right matrix system. Why it's crucial for dental success. I want to start by thanking our sponsors who make this webinar series possible. Colteen, Oral Arts Dental Laboratories, and Romero Dental Seminars. I also want to have all our listeners today to visit our YouTube channel, Romero Dental Seminars. Please don't forget to subscribe and to click on that bell so that you can get instant notifications every time we upload a new video. Our objectives for today are going to be identify the different matrix systems available, understand when a specific system is needed, and highlight the clinical applications of the TOR saddle system. So let's get into it. First objective, identify the different matrix systems available today. Now, I am going to highlight every matrix system that I currently use in my practice. Now, I use a number of them because, again, as I will share with you today, it really depends on the clinical case that you are confronted with in order for you to choose the best matrix system that actually applies to that case. So I don't want to leave out the old, if you want to call it that way, the old Tofflemire retainer with the Tofflemire band. Now, in this particular case, in this particular situation, as we all know, there are multiple types of Tofflemire bands. You have, as you can see on the left side of my screen, just a conventional or what we call the universal Tofflemire band. You also have the greater curve Tofflemire band, which has many clinical applications and many uses, and I have both of these in my office. And finally, you have the deep margin elevation modified Toffel matrix system or matrix band also, which is one that I normally use for my deep margin elevations. Now, there are some companies that make a specific deep margin elevation band that is a retainer-less type of band, and this is one made by Garrison. But the one that you're seeing here and the one that I use in my practice actually fits within this Tofflemire retainer. So it's not a retainer-less version, but you can use whichever brand you decide. I like using these deep margin elevation bands because they are they're less expensive than the ones made by Garrison. But not only the cost of them is the big difference, but most importantly, I just don't like the system that Garrison created for these bands to actually tighten them inside the patient's mouth. In my hands, has been very challenging to get it to work correctly, and many of these bands that are not inexpensive actually are damaged while I'm trying to place them inside the patient's mouth. So for that specific reason, I like buying these regular matrix bands that are already pre-cut or pre-modified, and they just fit in any regular Tofflemire retainer that you have in your office. The second system that I want to share with you is the TOR saddle contour metal bands. Now, again, these bands are the ones that I have in my office, and this specific band has a very specific clinical indication. I don't use it for every case, but I normally use it when I have a buccal cusp fracture or a lingual cusp fracture on a premolar or on a molar. I also use it when I have a first or second molar that I don't have any distal tooth to it. So let's say that I'm working on tooth number 19 and I don't have a tooth number 18, so there's no way that I can use a regular sectional matrix system, and I don't want to use a Tofflemire band. This band is specifically made for those cases, and that's when I use them clinically, and I really like them. They're not expensive. They're very easy to use, and they are, as you will see in one case that I'm going to share with you towards the end of my presentation today, they are very versatile and accomplish the job. They get the job or the work done. The next one that I want to talk about is the AutoMatrix system made by Dentsply. Again, this is another system that I have in my office. It's one that I use fairly frequently. I love using these bands when I'm trying to build my cores or when I'm trying to replace a cusp. Let's say that I have a number 19 or number 18 or number 30 tooth that is missing a mesiolingual or a distal buccal cusp. or a mesiobuccal or mesiolingual cusp. If I'm missing one or two cusps, this is the band that I like using. Very easy to place. It tightens very nicely. It's retainerless, so it gives you room for your wedges, for your clamps. I can actually put this band on a abutment tooth for my retentive clamp. So let's say that I'm working on tooth number 18, and I also have to place my W3 clamp on tooth number 18. This is the ideal band that I would use for a case like that. I have also used it for my MODs if I'm going to do a bulk fill type of restoration, and I'll share with you one case today when I decided to use this band for that clinical application. It has multiple clinical applications, but again, I also have different options in my practice. But this is one system that I enjoy a lot using, and again, I'll share with you some clinical applications. The next system that I want to share with you that I also have in my practice is the old version, or the first version, or the first generation of the Garrison ring. These were called the Bitine rings, and you can see them here that they have these thin bitines right at the ends of the ring. And these Bitine rings came in two different heights, so you can stack one on top of the other. Now, I normally just use the short version. I rarely use the taller version. I don't really, use them to put one on top of the other, and I'll share with you some clinical examples. But I'm going to share with you also why I would select to use this type of ring compared to just the conventional or the more modern or advanced generation of the Garrison ring. I still keep this in my office, and I keep them with their conventional or the original sectional matrix band. So these are also have they're less expensive. They're cheaper for you to buy. But again, it's not because of the cost. It's because of the clinical applications. And I'm going to share with you some of those clinical applications today in my presentation. And then we get to the more modern Garrison ring. I know that they have a new ring that just came out. I think they have a couple of new versions compared to this Composi-Tight, which is the one that I currently have in my office and that I use, and that I haven't switched to any other newer ring because, again, I like them. I'm used to them. They work well in my hands. But this system, as you can see, comes with three different rings, and each of these rings have different clinical applications. The ones that I use the most is going to be the blue, I would say 80% of the times, and maybe the green the other 19% of the times. Rarely do I use that orange ring, but this comes with these non-stick or Teflon matrix bands. Of course, more expensive than the conventional ones, but again, excellent. They have that coating inside the matrix, which allows the composite not to stick to it, so it gives you that advantage. And it comes also with these beautiful wedges, different colors, and depending on the size. You see there the small or the extra small, the small, the medium, and the large. And I like them because, again, these wedges are not really meant to create any pressure in between the teeth. They're actually just meant to keep or secure the sectional matrix in place. That added pressure that you need to create a slight or a minimal orthodontic movement of the neighboring teeth is going to be done by the actual ring. The pressure that the ring exerts into these interproximal spaces is what creates that slight separation, so that you can accomplish a very nice and tight interproximal contact. So now we're going to go to objective number 2, and it's to understand when a specific system is needed. I've shared with you, different systems, and you may be asking yourself, well, can I get just one of these systems and use it in every single case? Well, maybe the answer to that question may be yes. You probably are able to choose 2 of these systems, and you will probably get into 90% of the clinical cases. But my goal is to get to 100% of the clinical situations that I may be confronted with in my daily practice. So in this particular case that I'm going to share with you now, I'm going to use just the regular Tofflemire band. This is the regular universal band. It's not the greater curve. I'm using it, as you can see, on the right hand side of my screen, with the retainer, the conventional Tofflemire band retainer. And why did I choose this particular band for this specific case? As you can see on the left hand side of my screen, after I've removed the previous failing restoration, and I've removed the decay that was underneath this, the secondary decay that was underneath this restoration, you can see that on my distal box, I still have a contact. I still have an interproximal contact between that first molar and second molar. The other thing that I want you to see is the mesial beaks of my W3 clamp. As you are seeing here, if I were to use a Garrison ring, like the Composi-Tight Garrison ring, those rings, because of the width of the beaks of the rings, or the active portion of the rings being so wide, they will interfere with they will not go all the way down because of the beaks of my clamp. So just because of that, I gotta immediately think about, okay, what kind of ring or system can I use that would allow the band to go all the way down. It would allow me also to wedge without having any interference caused by the beaks or the mesial beaks of this clamp. So as you can see here on the right hand side, I was able just to use a conventional Tofflemire band. I still have a contact. I'm just going to create a little bit of wedge. So this box is not that deep. So I'm not worried about the anatomy, the perfect anatomy that I should be able to accomplish for that interproximal embrasure and occlusal embrasure of that distal marginal ridge that I'm going to have to recreate with my composite. So because of that, again, I'm able just to use a conventional Tofflemire band wedge so that I can create that orthodontic separation. You can see that the stiffness of this band allows me to go to get the band all the way down interproximally, even though I still have a contact that I was able to keep or maintain because there was no decay below that area. So in order for me to, I was trying to be as conservative as possible in my preparation. You can see that I have a nice and smooth distal box, the floor of the box, but I was still able to place this band because this band is very stiff. This universal band is very, very stiff. You will not be able, if you want to use a different type of Tofflemire band, like a dead soft type of band or a hoe band, you will not be able to get a hoe band down here because of the tightness of the contact. You would probably need to use a diamond strip to kind of alleviate that contact a little bit and then be able to get a hoe band. But again, it's not necessary because my universal band goes all the way down. I'm able to place my wedge. I'm able to to place that band and to create the contours that I need in order for me to recreate that interproximal contact. So this is a good example, and as you're seeing here, I'm now doing the centripetal technique to try to build that tooth back into function. And here I have all my layers that have been placed, and as you can see, I've also have created that distal wall that is now enclosing that class 2 and completed my restoration. All I have to do now is remove that band, remove the wedge, and start polishing and finishing my restoration. So here is a good example of a clinical case where you can still use a Tofflemire band and would be acceptable, and your outcome will also be ideal. Now let's go to a different clinical situation, that where I'm still going to use a Tofflemire band, but I'm going to use the modified version. I'm going to use the deep margin elevation version of that band. And as you can see, in this particular case, there was an extensive caries lesion that wrapped around the lingual. As you can see here on the right hand side, I'm now able to isolate that tooth and place a B4 clamp on that second premolar, which is not only retracting the rubber dam, but also retracting some of that tissue and giving me access to this lesion. Now, if you think about it, I have to first and foremost elevate that deep margin. I have to bring that margin up. And in this particular case, I'm going to elevate the margin using a resin modified glass ionomer type of material. And as you're seeing here, when you look at here on the left hand side, you can see that I'm holding with my fingers that modified Tofflemire band. That Tofflemire band that has been modified specifically for deep margin elevation. So for that deep margin elevation technique, I'm gonna sit that band all the way down, and because the band is so short, it goes all the way down, it sits all the way down. Actually, it even goes down subgingivally, slightly subgingivally on the mesial and distal boxes, as you are seeing here on the left hand side of my screen. And then I go ahead with the same Tofflemire retainer, as you can see out here. I'm going to make sure that I tighten that band. Now, because this band is so short and it's not flared out, you're only able to restore a couple of millimeters of that margin, which is actually what I want to try to accomplish on a deep margin elevation. But at the same time, you do not need to wedge. As long as you make it very, very tight, as long as you tighten that Tofflemire band, Tofflemire retainer very, very nicely, you're going to get this band to adapt perfectly well around that cervical aspect of the tooth, as you are seeing on the left-hand side. And then once I remove that band, you can see that I've been able to now elevate that margin maybe 2 to 3 millimeters, but I was also able to restore that lingual extension that secondary decay had underneath that lingual cusp. Again, this is a patient that financially couldn't afford any other type of restoration, so we were trying to do the best we could to to restore this last tooth on his arch, because he didn't have any molars distal to this tooth. So again, this is when these bands are very, very clinically applicable, because you couldn't use any other band to do this type of procedure for this particular patient. Now, as you are seeing, I was able to now remove the deep margin elevation band and use a conventional Tofflemire band, wedge against that tooth and the neighboring tooth, and now start doing my centripetal technique to build the proximal walls, and then the cusp buildup technique to develop the buccal and the lingual cusp and recreate nature as best as I can to have a very nice outcome. But again, as you are seeing, I'm still using the basic Tofflemire bands, one modified and one universal band, just to get to be able to restore this a tooth like this. So it all depends on the clinical situation, as you are seeing. Now, this is my example number 3, and in this example, I want to share with you the use of this AutoMatrix band. And again, the beauty of the AutoMatrix band is that it's a retainerless band, so it gives you a lot better view, less armamentarium in your patient's mouth. But again, look at this case. Look at the W8A clamp that I'm using on that heart-shaped second molar in order for me to retain my rubber dam, or to secure my rubber dam in place. Now I have prepped my mesial and the distal boxes, as you can see, very deep proximal boxes. And now I'm going to place this AutoMatrix band. Now the AutoMatrix band, you start tightening that band. So there's a little tool that you use to get right here, inserted right here in this little spiral that you see here, and you start rotating that band clockwise, and that little spiral. And what it does is that it starts tightening the band around the tooth. Once the band is completely tight, and it all depends on the size of the tooth, then all you do is just wedge interproximally, as you are seeing here. And for this particular case, I'm using Philip, which is a bulk fill dual cure resin composite made by Colteen. Philip comes with a self-cured adhesive system called Parabond. It's called Parabond, and it has 3 bottles. And the 3 bottles is all dependent on what you want to do. I only use for this case 2 of the 3 bottles, and that is because I'm using a total etch technique for this dentin, and then I'm going to rinse and dry, and I'm going to mix a drop of the yellow and a drop of the red A and B bottles of the Parabond, and this is a self-cured adhesive. Now, if you want to do a selective etch technique, then you would use that 3rd bottle. So you will do selective etch of the enamel. You will use bottle number 1, which is a mild self-etching acid that goes directly into the dentin, and it's a green bottle, and you apply it. It's a no rinse primer, so you just apply it into the dentin, leave it there for 10 to 20 seconds, and then you mix A and B, which is the red and the yellow, and apply it for that self-curing capabilities of the adhesive. Now, when I use Philip, I do want to make it clear that I inject it into the cavity, and I allow it to self-cure for 5 minutes before I light cure it completely. So I never use my light curing unit and I immediately light cure this dual cure material. I always allow it to self-cure for 5 minutes, and then I go back and light cure. And the reason why I do that is because I don't want to create any polymerization shrinkage stress in that recently created hybrid layer that I've done with my self-etching adhesive. So again, this is just the way that I personally do it. This is the way that I would recommend you do it, because it's the best way that you can do it. But this is the only way I use bulk fill materials. I really don't like using any light cure bulk fill materials in my practice. If I'm going to use one, it's going to be a dual cure one, and I'm going to allow it to soft cure before I put my cure in. Right? But as you can see, once I remove that AutoMatrix band, even though you do get a lot of excess with that band, I want you to see the before and after photos and look at those beautiful contours of this bulk fill restoration. Look at the occlusal embrasures, the buccal embrasure, the lingual embrasure on the mesial and distal aspect of this tooth. So again, even though you do get a little bit of excess, you get more excess than what you would get with a sectional matrix. You're still able to remove that excess, and I use soft flex disc. I normally use a coarse and a medium, and I get in there and I remove all my excess there. I control it as best as I can when I'm adapting that band as best as you can to the tooth. But you're always, I do want to make that clear, you're always going to get a little more excess using an AutoMatrix band compared to anything else. But there are some clinical indications, as this is one of them, where you want to choose that specific type of band versus others. Now, when would you choose to use your first generation Garrison ring with the Bi-Tine rings and your first generation sectional matrix bands? And this is a good example. As you are seeing here, I have a W3 clamp holding my rubber dam in place. This W3 clamp is on that second molar. Now, if you look at the beaks, the mesial beaks of that clamp, I would never get any Garrison, newer version of Garrison rings that are so wide. I would never get them to fully seat in that distal, to hold the band on that distal area of that first molar, or in between the distal and the mesial area of that second and first molar, because they're just too wide. So this is a good example of when I use this first generation Garrison ring. And you can see what it's doing for me. I still have my wedges. I'm able to create some ortho. I actually have a wedge on the lingual, a wedge on the buccal, and you can see that the Bi-Tine rings are placed outside or mesial to those wedges. Now, I also want you to see how beautifully and well adapted that band is to the distal contours of the tooth. And why? Because the box, the proximal box, is not that wide enough. I still have enough tooth structure in order for me to have those Bi-Tine rings to exert that added pressure, or that the added pressure in between these teeth, in order for them to create this separation from the first molar, and this slight separation from these two teeth, so that I can create a nice and tight contact. Once I build my composite and I'm done with my restoration, I then remove the wedges, remove the ring, and I have to remove these bands every single time using a hemostat. They're so tight in between these teeth. And I know that you also experience the same thing, but I'm just giving you, I think, a good example of when a Bi-Tine ring or the first version of the Garrison ring will be used compared to just using the regular or the more newer versions of the Garrison rings. And again, if you look at the lesion that we started with and where we're at once we're done with the restoration, look at the beautiful contours that we were able to accomplish, and that very nice and tight contact in between that first and second molar using a very old sectional matrix system. But again, clinically, in my mind and in my hands, it still has very good clinical applications. So when would I use my Composi-Tight Garrison rings, which is the version that I have in my office? And this is a great example of using this system. So what I'm going to do here is I'm removing a composite. This patient had two composites that were neighboring to each other, a back-to-back type of case, where one of the composites was over contoured, the one on the premolar, and the other one was under contour, and their anatomy was really not ideal. Patient was having a hard time just flossing and keeping that area clean. It was very tender in between these two teeth. So we decided to remove these restorations and to redo them for the patient, just in order for us to get better anatomy. And this will allow the patient just to keep that area nice and clean. So first, I decided in this particular case, instead of doing a back-to-back, same time, same clinical time, both restorations, I decided to do one at a time. And again, why? Because this one was the one that was over contoured, and you can see how flat the mesial surface of that first molar is. So I decided to do one at a time. You can see how wide that preparation on that premolar ended up being. So of course, if I were to use the bitine rings, these bitine rings, or the older version of the Garrison, they will actually impede into my preparation and would deform my restoration. So this is when you want to use this green ring, which is the wide prep ring from the Composi-Tight system. And one of the things that you have to understand about this specific ring is that it exerts less pressure than the blue ring or the orange ring. So you're not going to get as much interproximal separation, and that's why I decided to do one at a time. So I was going to use the green ring on the premolar with the idea to use the blue ring from when I was going to restore the first molar, so that I can then exert additional pressure and create a very nice and tight contact in between these two teeth. So here I'm using that green ring first. As you can see, I have here my band, and I'm ready to restore that first premolar. Again, these are exerting less pressure, but because they're the wide prep ring, you can see that the beaks of these rings are not impinging at all in the anatomy or affecting at all the anatomy of that proximal wall. So now once I'm done with the first restoration, I'm going to go to the second tooth. And again, you can see a wide box, but I still have some tooth structure here on the lingual, tooth structure here on the buccal, and this is already restored in order for me to use the blue ring. And with the blue ring, not only that the beaks are narrower, but they also exert more pressure. So now I'm going to get a little bit of separation in between these two teeth and achieve a very nice, not only anatomical, but very tight interproximal contact to actually make this better for the patient, because the patient was complaining actually of the lack of that contact, keeping the food away from that gingival embrasure. So now I have the new ring. I'm done with the preparation of that box. And with that new ring, of course, I'm going to be able to recreate that interproximal contact. So now I've given you examples of every single clinical application for different matrix systems that you can have in your office. My last objective for today is to highlight the clinical applications of the Tor saddle contour bands, because I mean, these bands are not commonly used. I mean, I don't go to every office and see every general dentist out there, at least in my area, knowing about this band or using this band in their office. And if you've never used this band before, you really don't know what you're missing. And I'm going to share with you a clinical case to exemplify the use of these bands. And, again, this is one of multiple clinical applications that I feel that this band has. This is the tooth that we're going to restore, this mandibular second molar. It's actually tooth number 31. You can see that I've used a W3 clamp. The beaks of the clamp are seated in my rubber dam, and keeping the rubber dam in place, are seated in the cervical aspect of the tooth. But again, if you think about it, how in the world am I going to hold a sectional matrix band back here if I don't have a tooth distal to the one that I'm working? Impossible. How am I mean, I can get a Tofflemire band, but the problem that I was having here is that this patient had very, very tight contacts. So I had to section my rubber dam, and you were seeing here that I needed to use a little bit of blockout resin to seal my rubber dam in some areas, because they were so tight. And I know you have this same problem that I have. These interproximal contacts were so tight that every time that I would push my rubber dam in between the contacts, a little bit of that rubber dam will tear, and I would get a little bit of leakage. So instead of me changing to a new rubber dam, what I did is I just added a little bit of blockout resin to seal my rubber dam and not get any saliva or bleeding that was coming from underneath the rubber dam to my operative field. So now I can't use a Tofflemire band, because my Tofflemire band would have to go all the way in between these teeth. And again, don't forget, I have really, really tight contacts, which, as you know, also makes really hard or difficult for you to get a Tofflemire band to fully seat in between that area. So what is the best or the next best thing? Definitely a saddle matrix band. So here I'm using my caries detection die just to remove and identify some cracks that the tooth had in the distal. As you can see, I was able now to clean that unsupported enamel. There was a little bit of a fracture line on the enamel that also extended. As you can see right here, that fracture line extended into the dentin. So if it extends into the dentin And this is what I call my peripheral seal zone. I want to make sure that I don't have any fracture lines on my peripheral seal zone. So because of that, I'm going to go ahead and, as you can see, using a small diamond burr, maybe a number 2 size round diamond burr. You can also use a carbide if you decide. I go side to side just on that specific area where that fracture was until the fracture is completely eliminated from the dentin. So there is no extension of the fracture past that DEJ anymore. And now I have a fracture-free and caries-free peripheral seal zone. So now I'm going to go ahead and I'm going to clean my tooth with a little bit of aluminum oxide. I'm using a 29 micron aluminum oxide with my Aqua Care unit just to blast and clean that dentin, remove any of my smear layer or compact my smear layer there, and then just start applying my primers. I use a two-step system. I use OptiBond Extra Universal 2-bottle system, a primer and a bonding in 2 separate bottles. That primer is a self-etching primer that I'm going to apply on top of that dentin. My second layer is then going to be the adhesive. I'm going to eliminate any excess of the adhesive, light cure, and then once I light cure, I'm going to do my resin coating layer, which is a very thin, half of a millimeter thick layer of flowable composite. I normally use for that my Brilliant Everglow Flow, and I just place it only on the dentin. I try not to extend it into my enamel, so I keep it into the dentin. I thin it out with a probe, and then once it's thin out and cover my entire dentin, I'm going to light cure. And once I do that, now I'm going to place my saddle band. And as you can see, what I like about the saddle, the Tor saddle contour bands, number one, they're pre-contoured, so they have just kind of like the same design as the sectional matrix, right? It has a double contour from mesial to distal and from occlusal to gingival, but it also has this spring that you connect to the band, and you can see that it exerts the pressure towards the band and it pushes the band towards the mesial, allowing the band to saddle around the distal surface of the tooth. Now in this particular case, I needed to secure my band, and if I have to secure it for whatever reason, if it's moving on you, I just use a little bit of blockout resin. And I want you to also see, because I did not have a tooth distal to this second molar, I didn't have anything, of course, to push this band towards the tooth. So what do you see back here? You see a piece of Teflon tape, a roll of Teflon tape that I'm literally packing distal to my band in order for me to adapt the band better towards the tooth. So that's just a trick that I'm sharing with you here. That's how I do it when I don't have a tooth to the back. But I want you to look at that nice contour that I'm going to be able to accomplish because I'm going to follow the contours of the band. So here I'm placing I'm just reinforcing my central stop zone, which is on that axial wall, axial pulpal floor. And I'm going to place a rib-on fiber, as you're seeing here, in a bed of flowable and microhybrid composite. I then light cure that and start building my dentin my dentin replacement. I'm using a dentin shade for my entire restoration. I'm just talking about the different layers that I'm doing. This is layer number 1. I'm building my proximal walls, and I do a couple of layers in order for me to build that proximal wall. I light cure the proximal wall, and then I'm going to do my dentin replacement. I transform that cavity into a class 1 type of preparation, and I'm going to then start just placing my dentin layer, a couple of horizontal layers of composite, all the way up until I get to that DEJ. Once I have restored to the DEJ, I do what I call the reverse acid etching. I'm going to acid etch my enamel, rinse and dry, and then I'm going to do my final layer, which is my final enamel replacement, in which I do the centripetal, the cusp buildup technique, where I'm going to do one cusp at a time, which is definitely going to just decrease the amount of polymerization shrinkage stress that is being built in each of these increments, because they're thin and because they're very small and because they're one at a time. So for this occlusal surface, I probably did 3 or 4 different layers, as you are seeing here. This is now my completed enamel replacement. I'm then going to remove my band, remove my rubber dam, and then just go ahead and do my final adjustments, occlusal adjustments, remove any flash or excess that I have. And I always get a bite wing after I complete a restoration. And as you are seeing here, I don't have any excess to the distal of my restoration. You can see a little shadow right there, and that is my fiber reinforced, or my fiber reinforcement, my ribbon fiber in that central stop zone. And as you can see up here on the occlusal, the enamel layer was very adapted very well to my enamel preparation of my of that cavity. So at the end of the day, we get a nice restoration, and I think that this is a really good example of when these Tor saddle bands are clinically applicable. I hope that you really enjoyed today's presentation. I know that there were a lot of clinical tips that you can use tomorrow in your practice, and please don't forget to leave us a message or ask us any questions you may have in our comment box, because I promise you that I'm going to answer any questions you may have. The idea is that there's a continuing learning process here, and we want to make sure that we get back to any questions or comments you leave in our comment box. Thank you very much for watching our seminar today, and I hope to see you on the next one.